Hello, and welcome to another Facebook Live broadcast with MedStar Health. My name is Sarah Ridenour, and today I'm joined by cardiac electrophysiologist Dr. Sanjeet Sidhu. And today we're discussing the most common type of arrhythmia, atrial fibrillation or AFib, and its risk factors, symptoms, and more. If you'd like to learn more, then stick around, give us a like to let us know you're watching, and ask your questions in the comments below. We also encourage you to share this broadcast with your friends. Before we dive into our questions, Dr. Sidhu, would you mind telling us a little bit about yourself and your background?
Absolutely. Hi there. My name is Dr. Sidhu. I'm one of the, as you said, cardiac electrophysiologists with MedStar. I recently joined the group in the summer after completing most of my cardiology and electrophysiology training in town at Hopkins. I describe myself as a heart rhythm doctor. I think that's often easier to understand for patients, just because electrophysiology can be a big term. But I focus my efforts on managing things like atrial fibrillation, as well as other things, including pacemakers and defibrillators and the like. But today's discussion will be focused on AFib, since it's such a big problem, and I hope I can answer some questions.
Great, thank you. We really appreciate you being here.
My pleasure.
So first question we'll start off is, what is AFib and what causes it?
Absolutely. So atrial fibrillation is a chaotic rhythm in the upper chamber of the heart. It's sort of it's simply say the atrium are just fibrillating. They're just going like this. And there are many different things that play a role into atrial fibrillation, a lot of risk factors that play a role that I kind of think of it as sort of a heart age, meaning age plays a role, how you take care of your heart, high blood pressure, diabetes, coronary disease, like heart attacks play a role in terms of making AFib more common.
And so who typically gets AFib?
AFib is commonly a problem of the elderly. So, we expect to see it by the time people hit age 80. About 1 in 9 Americans will have atrial fibrillation. But that isn't to say that everyone doesn't get AFib. I mean, AFib can affect people in their 20s, 30s, 40s, 50s. Usually when people are younger, I start to think of other potential causes for their AFib, but it can affect really any age with a predominance in the older age group. And those patients who develop atrial fibrillation, it's actually more common in white Americans. It's more common in people who are obese, and those other things that I mentioned, more common in patients with high blood pressure, diabetes, coronary disease, and the like.
Okay, so then kind of going along with that, what are some of the symptoms to indicate someone might have AFib?
So interestingly enough, many patients have no symptoms from AFib whatsoever. They'll show up, they'll come to their doctor's office, they'll get a routine EKG, and they'll be told for their first time that they're in atrial fibrillation. Other patients, and these are the patients that often present earlier, are those patients who have some symptom. And it could be a skipped heartbeat. Sometimes patients describe it as a fluttering in their chest. And other times it can be quite severe where patients come in with chest pain, shortness of breath, lightheadedness, and even flat out passing out. So there's a big gamut in terms of the symptoms that people can experience, to none to very severe.
Okay. And so you kind of mentioned this when in answering that question, but are there tests to figure out if someone has AFib?
Absolutely. So, it's easy when someone is in atrial fibrillation when they come to medical attention, because you can get an EKG and it can clearly demonstrate this atrial fibrillation rhythm. What's more difficult is in patients who start out with AFib. It starts out as paroxysmal, meaning that people go in and out of AFib. And so it's possible that a patient may describe this fluttering in their chest, and they show up at their cardiologist or doctor's office, and when they check an EKG, it's completely normal. And that's just because they're not having AFib at that time. And so that's when we start to use other tools. Maybe we'll send patients home with a little patch monitor. It's a sort of monitor that you wear on your chest. You can wear it for 24, 48, or even hours, or even up to 2 weeks. And there are other sort of commercially available things that people will use. Often patients' blood pressure cuffs will have a little signal on them that looks like a little EKG that'll tell them if they're in irregular rhythm. It's not a diagnostic tool for AFib, but it does help give people a clue that they may have AFib. And there are even other wearable devices that, these smartwatches and things that have monitors to tell you that you have an irregular rhythm and maybe a clue that you might have atrial fibrillation.
Okay, thank you for explaining that. So does having AFib, does it increase the risk of developing other possible health conditions?
Yeah, so AFib has a lot of things that are associated with it. There's an increased risk for hospitalization. There's an increased risk for stroke. That's probably the one that we worry about the most. There's an increased risk for cognitive decline as you get older. There's an increased risk for heart failure. So there's lots of things that are associated with atrial fibrillation that, we as cardiologists and cardiac electrophysiologists think about deeply to try to prevent in patients going forward.
So it's really important to seek treatment if you do have AFib because it could lead to other things.
Absolutely. And in fact, it's best to get treated earlier in your diagnosis, and it's something we can talk about later. But the earlier you present to attention of a cardiologist or cardiac electrophysiologist, the easier it is for us to treat. And often as patients sort of progress to the later forms of the disease, it becomes harder to manage medically.
Okay. So are there certain activities that people should avoid if they have AFib?
Actually, there's no specific activity that patients should avoid, but in fact, we actually encourage cardiovascular exercise. And those patients who can get 30 minutes a day, 5 days a week of moderate intensity exercise, which are the current recommendations by the American Heart Association, those patients tend to have lower risks of AFib going further. So even if you have a diagnosis of AFib, staying physically active and physically fit can reduce your burden of atrial fibrillation in the future. Now, there is an interesting caveat to that there is a bit of a paradox for patients that are high-level endurance athletes, marathon runners and the like, that those patients, as they get older, can actually have a little bit more atrial fibrillation, which is a very interesting thing to see in our very fit, very highly trained individuals.
That is interesting. And so touching on treatment again, what are the different types of medication used to treat this, and how do they treat it?
Yeah. So I think whenever I talk to a patient who has newly diagnosed AFib, there's sort of two realms of treatment. As I mentioned earlier, one of the biggest things that we worry about with atrial fibrillation is the risk of stroke. And I think one of the things that we'll touch on later is that as well. But the risk of stroke is modified by a few stroke risk factors. And in patients who have a greater than 1% risk of stroke per year, we really strongly recommend them to go on some sort of blood thinner to help reduce their risk of stroke. And that's independent of the management of AFib itself. That is just because AFib has an increased risk of stroke. Now, in terms of the medications to help manage AFib, they start out with medications that help to control the heart rate, things like metoprolol, things like cardizem, which often both primary care doctors and cardiologists use very routinely. And then as you sort of get more specialized, we start to use more drugs like antiarrhythmic drugs, of which there are a whole slew of them, ranging from things like flecainide all the way up to all the way up to things like amiodarone. But there's a whole slew of drug therapies that we can use as a first line for management.
So it sounds like there's a lot of options to take if you have AFib with treatment wise.
And a lot of that's dictated based on what other medical problems the patient has, and that helps tune their medical regimen.
Okay. And will surgery, could that cure an arrhythmia or could it come back if you choose to get surgery?
Yeah, it's a good question. With atrial fibrillation, and you mentioned cure, with atrial fibrillation, I don't think of it as a cure. I think of treatment to suppress AFib. And the reason being is that as we get older and our heart stretches and it dilates and you may get some more scars as you get older, you're more likely to have more AFib. So all of our management options work to decrease the burden, decrease the symptoms, and potentially delay your recurrence of AFib. And what we use in terms of surgery, it was first described in the 80s and 90s, and it was actually a surgery. It was open heart surgery where they would, cut apart the atrium and sew it back together to try to reduce your risk of AFib. From there, it's progressed to procedures that we can now do as a minimally invasive procedure through the vein in the leg, where we can go up and cauterize or freeze the areas that are drivers for AFib. And by doing so, in patients who are optimal candidates, we can see a significant reduction of greater than 95% burden reduction in their AFib. So we can really help our patients, both with medicines and also with minimally invasive procedures called cardiac ablation to help control their atrial fibrillation.
Wow. Okay. Well, thank you for explaining all of that. I'm going to take a minute to pause and just say, if you're joining us now, thank you for tuning in. We're speaking with cardiac electrophysiologist, Dr. Sanjeet Sidhu. We're talking about AFib and its risk factors, symptoms, and more. We have more to talk about, so keep watching. Share this video with your friends and give it a like to let us know you're watching. And also, if you have any comments, please ask them in the comments below. And if you have any questions, ask them in the comments below. So moving on, after a procedure, do they still need to be on blood thinners?
That is a question that is still hotly debated, and the answer is still unknown. But the current guidelines would recommend if someone warranted a blood thinner prior to ablation, they warrant a blood thinner after ablation. Now, there are current ongoing clinical trials that are trying to answer this question, that if you have very close monitoring of AFib, and by close monitoring of AFib, I mean an implantable device that is monitoring every single heartbeat to look for atrial fibrillation. If you have that level of close monitoring, the question is, can you come off an anticoagulant or come off the blood thinner? And right now, the guidelines would recommend no. If you need a blood thinner beforehand, you should be on a blood thinner afterwards. But there is some more data to come on this, and that answer may change soon.
Okay. This is an interesting question, I think. Is AFib hereditary, and could someone pass it down to their children?
It's a very interesting question. So in patients who have atrial fibrillation, there are certain genetic, what we call polymorphisms, but certain small changes in your gene that make it more likely for you to have AFib. Now, there are some rare genetic mutations, some ion channel mutations that make it much, much more likely to have AFib. But in general, for most patients, there are some genes that may make you a little bit more likely, that may have inherited from your mom or your dad. And I start thinking of that more and more with patients who present with atrial fibrillation before the age of 40. That starts cluing into my mind. But there's no clear cut, if you get a gene test and you have this gene, you're going to have AFib. It doesn't unfortunately work like that. It's multiple genes that play a role into atrial fibrillation.
Okay, that's good to know. And so now, what can someone do to prevent AFib or decrease their risk of getting it in the future?
Yeah. So, a lot of that has to deal with modifying those other risk factors that play a role into atrial fibrillation. So, maintaining a healthy body weight. So there's actually good data that those patients, even if you have AFib, that if you can reduce your body weight by 10%, you can actually dramatically reduce your recurrence rates of atrial fibrillation. And the opposite of that is true, that if you also gain weight, that you have a higher risk for recurrence of atrial fibrillation. So weight plays a very tight role with AFib. Making sure you're not drinking alcohol in excess. So staying under moderate or less alcohol intake can actually reduce your risk of AFib. Daily exercise, as we kind of talked about before, will also help reduce your risk of AFib. And then the other things that you work on with your doctor, making sure your blood pressure is well controlled. If you have diabetes, making sure your diabetes is well controlled. There are other sort of structural problems with the heart that can drive AFib, making sure those are addressed, with a cardiologist, for example, are also ways to help control AFib, either prevention, or if you have it, reduce recurrence.
Right. So it sounds like living a healthy lifestyle can contribute a lot to just decreasing your risk.
Absolutely.
And so this, I think, is another important question. My doctor told me I have AFib, but I don't feel anything. So do I still need to have it treated?
Good question. So in patients who are asymptomatic, I mean, they absolutely have no symptoms with atrial fibrillation, what we mostly focus is on their stroke risk. So their stroke risk, regardless if they feel it or don't feel it, is dictated based on other things like their age, blood pressure, diabetes, things like that. And you make a call with your doctor on whether or not you need a blood thinner or some other way to reduce your stroke risk. That is irrespective of whether or not you have symptoms. Now, if you don't have symptoms, if you truly don't have symptoms, there isn't, the main goal for treatment at that point is keeping your heart rate under control. And that's something, again, you can work on with your doctor. But that being said, symptoms with AFib can be very subtle. And in some patients, they can just sort of blow off their symptoms of AFib based on the fact that they're just getting older. They feel like they're slowing down just because they expect to as they get older. And one of the things that I do with many of my patients is if they come in with a new diagnosis of atrial fibrillation, I will try to get them back to normal rhythm and see, do their symptoms improve? And if they do, they may have just been blowing off their AFib symptoms just based on just the sensation of age. So I really want to make sure if someone's truly asymptomatic or not. If they truly are asymptomatic, then it becomes worrying about your stroke risk and worrying about your heart rate.
Great, thank you. So my next question is, what type of doctor treats AFib? Obviously you, but maybe where could someone, start out seeking treatment for it, and then are there other options of doctors they could see as well?
So with AFib, the burden of AFib is so high in the sense that there's 6 million Americans that have atrial fibrillation. And as a result, the types and numbers of doctors, nurse practitioners, physician assistants that manage AFib have to be a bit varied. So, we utilize the primary care physicians, the cardiologist, and at some point it is worthwhile seeing a heart rhythm specialist because, at some point those treatment strategies of ablation, of rhythm controlling agents, antiarrhythmic drugs, are really limited in terms of their, to people with levels of expertise like myself and other cardiac electrophysiologists. So there's a whole gamut of people that deal with AFib. Starting with your primary care doctor makes sense. And then going from there to a cardiologist or even a cardiac electrophysiologist makes sense as well.
Okay. Yeah, I think it sometimes can be hard for people to know, where to start out if they're experiencing issues. So that's why it's good to have you here and, bringing awareness to it. And I think, yeah, with most things, it's a safe bet to start with a primary care doctor and they'll guide you from there.
Yeah, I usually think of the primary care doctor as the quarterback of your healthcare. So starting there and letting them direct the where the next step is makes a lot of sense. But if you have AFib, I think it makes sense to see a cardiologist and at some point a cardiac electrophysiologist to help sort of pick the best option for care for you.
Right, exactly. So you kind of touched on this also a little bit, talking about living a healthy lifestyle to decrease your risk. What sort of lifestyle changes should someone make if they have AFib, in regards to diet and exercise, things like that?
All of us can do more exercise, so that's definitely a big role. Like I said, minimum 30 minutes of moderate intensity exercise, 5 days a week is what the sort of lowest bar of the recommendations are. Trying to achieve a healthy body weight in a healthy way, right? You don't want to do any fast dieting, but trying to stick with a heart healthy diet or other diets that you can see, sort of the Mediterranean diet or things that are recommended by your doctor are ways to lose weight in a healthy way. I didn't mention this earlier, but I'm glad you asked the question again. Some patients and many patients with AFib have this issue called sleep apnea. Sleep apnea is also a very common problem. And often the people that tell you have sleep apnea is usually your partner, because usually the first signs are snoring and you sort of gasp for breath in the middle of the night. You may find that you have significant fatigue throughout the day, sort of nodding off while you're in front of a computer or while watching TV. This also plays a large role in AFib. Getting that managed as well, or diagnosed and managed, is also another way to help reduce your risk for recurrent AFib.
Great, thank you. So next question, I've heard about a study that showed wearables could potentially detect AFib. Do you think it's important for people with AFib to have such wearables, or what is your opinion on this?
That's a very good question. The study I'm assuming the commenter is referring to is the Apple Heart study. Made a big splash over news media back in 2019, included over 400,000 patients. So it was a very helpful thing to add to literature, and a lot of people have Apple Watches. That being said, in terms of my recommendation to patients, it really depends on what the overall issue is. If they have a known diagnosis of AFib, and the question about monitoring is to look for recurrence rates or what have you, or assess burden of AFib, the Apple Watch can't quite, or in other wearables at the moment, can't quite answer that as well. Where the Apple Heart study came into play is to look for screening, is to find new diagnoses of atrial fibrillation. So in patients who have a smartwatch or a wearable or something like this, it is helpful as a screening tool to pick up AFib. But once you have that diagnosis, I think that's a discussion you have with your heart doctor, your heart rhythm doctor, as to if you need a monitoring device and if any of them is useful for you. It is important to realize that, I'll say both of my parents have Apple Watches. and they both will check an EKG and they'll send it to me and say, is my heart okay? I will stress that the Apple Watch alone cannot answer that question. And that's where you need to see, your heart doctor. It really is only a rhythm monitoring device. And only then, it's not perfect. The what we call the positive predictive value from that study was on the order of 70% or so. So it's not always right. And it doesn't pick up all the AFib.
Right.
If you
Thank you for
need
explaining that. Oh, go ahead. Sorry.
No, I was saying if you're someone who's worried about symptoms, flutters, palpitations, what have you, that's something where, the Apple Watch can play a role, but really you should be seeing your doctor and getting something which has a little bit more data involved, either a Holter monitor or in some cases an implantable loop recorder to look for these arrhythmias.
Right. Thank you. Yeah, that's really interesting. Thank you for explaining that. So obviously COVID is, top of everybody's mind right now. It's a very hot, discussion. So first off, is there a connection between AFib and COVID? Can having COVID put you at a higher risk for AFib? And if so, does age play a factor in that?
I think there are two parts of AFib, or sort of parts of this story of COVID and AFib. One is that we know that, or we've seen in large studies that patients who have COVID and who are critically ill with COVID in the ICU, for example, those patients have an increased risk for having atrial fibrillation, and more so than patients who don't have COVID in the ICU. And the reason behind that may be because their blood oxygen level is low as a result of COVID pneumonia. COVID can actually cause a direct inflammatory response in the heart in some cases. So whether that's playing a role, whether the overall stress of the body is playing a role, these can all sort of drive AFib. And then on the flip side, atrial fibrillation, if you have atrial fibrillation and COVID, there is an association that you will do worse, that there's an increased risk or increased association of death or major adverse cardiovascular events like a heart attack. Now, what's the chicken, what's the egg, what came first? I don't think that's quite clear. But there's a link on both sides with the COVID and AFib story. Now, in terms of the age question, I think that's still out there in terms of whether COVID affects different patients in terms of the incidence of AFib at different ages. I will say that anecdotally, I've had more patients at younger ages who've presented with AFib who had a previous history of COVID. Whether or not that's related is unclear, but I think there is some concern that the effect of COVID on the heart may be driving up some AFib burden.
Right. So then going along with that, are there risks to getting the COVID vaccine for those with AFib? And would you recommend that that they get the vaccine?
Yeah, I don't know. I'm not aware of any risks of getting either one of the mRNA-based vaccines, the Moderna or the Pfizer vaccine, if you have a history of atrial fibrillation. And I've been recommending that to my patients who come in, who meet CDC guidelines for getting the vaccination. So, I think I would not dissuade anyone from getting the vaccine if they have AFib. I think that is not a contraindication. I would say go ahead and get it if you're eligible, if you're a candidate. And it goes along with the same lines, is that if you have AFib and you develop COVID pneumonia, there is an association with increased risk for death or heart attack. So you could make an argument that those patients, it may be more beneficial for them to get the vaccine to prevent them from getting COVID pneumonia and having those increased risks.
Right. Well, thank you for answering those. Like I said, COVID and the vaccine are at the top of a lot of people's minds right now. So we appreciate you answering those. We have received some questions from our viewers. Our first question is from Les. Thank you for your question. And they ask, I am in AFib all the time. Is there no hope other than a pacemaker?
This is a question we get often. And what I sort of touched on this earlier. So the AFib progresses from something called paroxysmal AFib, meaning that you go in and out of it, to persistent AFib, meaning that you're stuck in AFib unless we do something to get you out of it, like a cardioversion or medicines or what have you. But each episode of AFib lasts more than 7 days. And then you go to the point that you have long-standing persistent atrial fibrillation, which is you're in AFib all the time for more than a year. And sort of patients sort of march down this gradient of paroxysmal to persistent. And like I said, it's easier to treat when someone has paroxysmal AFib. That being said, even if you have persistent AFib, it doesn't mean that you've lost hope. It doesn't mean that there's no options for you. There are definitely options to help manage your AFib, whether that's, with medicines, with ablation, with even something more recently called a convergent ablation, where we do both an ablation from the inside of the heart one day and the surgeons do an ablation from the outside of the heart another day. So there are ways to manage AFib, and we offer all of those here to help control patients' AFib, even if you progress to persistent. Is it harder to treat? Yes. I warn all of my patients with persistent AFib, I temper their expectations to say, you may not have had as good of a response as if you had the early stage of AFib, but it doesn't mean that there's no hope.
Okay. And our next question is from Martha. Is pounding beats an indicator of AFib?
Yeah, there's a lot of things that can cause, pounding heartbeats, palpitations, skipped heartbeats. And that's where one of these screening devices helps to look for what rhythm is happening when you have a symptom. That symptom rhythm correlation that I find so helpful to find. And that's where either we wear a monitor, that's where sometimes these wearable devices that you can get, like the Apple Watch or the Cardio Mobile or the AliveCor, these things can play a role to see when you have your symptoms, the pounding heartbeats, what rhythm are you in? Because it's not just AFib. There are things like SVT, there are things like PVCs, which are early beats in the bottom chamber of the heart, that can cause similar symptoms that are not atrial fibrillation.
Okay, thank you. Our next question is from Liz. Thank you for your question, Liz. She asked, can you talk about both thyroid and menopause and interactions with AFib?
Yeah, so in general, I expect that with thyroid dysfunction, particularly hyperthyroidism, those patients who present what's called thyroid storm, where their thyroid is overactive, they actually can present an atrial fibrillation. And that is one of the things we want to rule out for patients who come in with AFib. We want to rule out they don't have an overactive thyroid gland. Now, in patients with low thyroid, whether or not you can develop you can gain weight and sort of metabolic, derangements from low thyroid, and that will play a role in AFib for sure. And also, similarly, there are drugs that we use for AFib that can affect the thyroid gland. So these two things also play a role as well. Now, with menopause, there are sex-related changes that happen with AFib. AFib tends to be more common in men, but it's still very common in women as well. And particularly as you get older, past menopause, your AFib rates increase. So we definitely see more AFib in those patients as well.
Okay. Our next question is from Denise, and you talked about ablation before. So she asked, how successful is ablation for AFib?
It's a very good question. It's a conversation I have with each patient, and it depends on some patient risk factors, right? When I get an echo, how big is their atrium? When I get, check their blood pressure, diabetes, sort of how well are those other things controlled? In an optimal candidate, someone with early onset AFib, someone with, no other significant risk factors, I quote patients, with an AFib ablation or the single ablation, about a 60 to 80% success rate. Now that may seem low. And the reason that seems low is that the guideline, the clinical studies define a failure of ablation as 30 seconds of AFib in a year. And for most patients, that's probably not all that significant. Meaning that if you have an hour episode of AFib and you're having episodes of AFib maybe once a week, twice a week, if you had 30 seconds of AFib in a year, the clinical studies would call you as a failure of ablation. But I would consider that as a clinical success, that if I've driven your AFib to 30 seconds or a minute in a year, and meanwhile you were having an hour a week, I would consider that as a success. And I think the patient would as well, if their symptoms are that much improved. So often I look at burden. And with burden for optimal candidates, we're expecting to see about a 95% or greater burden reduction in AFib. So if you say, just to throw simple numbers, if you have 100 hours of AFib in a year, then maybe your AFib burden is less than 5 hours in a year. And I would consider that as a win for patients that are symptomatic.
Okay, Great. Thank you for explaining that. And thank you, Denise, for your question. Um, our next one is from Lori. She says, I am in AFib 100% of the time. Blood thinners don't work for me. What else can I do to help me reduce stroke? She also says, I have a pacemaker that I'm 100% paced and I've had 4 ablations.
Yeah. So I think that is a fantastic question. And I'm glad that that you bring up that question. So in patients who are, who have AFib, and whether or not it's persistent AFib, meaning they're in AFib all the time, or they go in and out of AFib, just focusing on the risk of stroke for a moment, are often our first line therapy is drug therapy. But over the last several years, there is an alternative option. There's basically, the way I describe it to the patients is that the atrium, there's all these sort of different parts of the atrium, but there's a particular part of the atrium called left atrial appendage. It's the sac that comes off the side of the heart. And greater than 90% of clots that form in the heart that can break off and cause a stroke form in that area. So one of the options that the surgeons described many years ago was, let's just close off that area. Let's either cut it out or suture it closed, because patients don't really need that for their heart function. It works reasonably well, but obviously that's an open surgery. And so more recently, we have this option called the Watchman. The Watchman is a device that sort of does the same thing, in that it goes in from the vein in the leg, similar to an ablation. As she said, she had 4 ablations in the past. So similar to an ablation, we go up from the vein in the leg and we deploy this device that looks like a plug, and it closes off that appendage. And by doing so, we reduce their risk of stroke, similar to the fact that if they were on a blood thinner. So usually those patients will need to be on a blood thinner for about 6 weeks. They'll need to be on some antiplatelet drugs for 6 months. But after that, we put them on just aspirin alone. And their risk of stroke is similar to as if they had a blood thinner, but they don't have that same risk of bleeding. So that there is definitely an option for patients who can't be on a blood thinner for bleeding issues or what have you. There is an alternative to managing their stroke risk.
Great, that's good to know. Thank you. And thank you for your question. Our next one is from Debbie, and she says, I started having AFib after a surgical procedure at age 50. Is that unusual?
No, it's not unusual. So the commenter didn't say what type of surgery, but after cardiac surgery, AFib is actually quite common. 30% or more people will have AFib after cardiac surgery. After non-cardiac surgery, AFib is still common, and it can happen, or it can be triggered as a result of the stress of surgery or the stress of recovery, or simply that it was picked up because the patient was on telemetry in the hospital, and they may have had AFib prior to surgery as well. So it is not an uncommon thing to see. And it's important to realize that in patients who've had AFib after non-cardiac surgery, that their risk of stroke is similar to if they just had AFib without surgery, in the sense that the fact that it was caught or triggered in the setting of a surgical procedure shouldn't change the discussion as to whether or not they need a blood thinner.
Okay, thank you for explaining that. Our next question is from Erica, and this one I think is an interesting one also. She asks, can there be another cause to a fluttering, irregular beating feeling, or is it always AFib?
Yeah, absolutely. There's many causes for an irregular heartbeat or sensation of fluttering in your chest. People can have isolated extra beats in the upper or bottom chambers of the heart called PACs or PVCs. You can have something called atrial flutter, which is a different type of arrhythmia. You can have something called SVT, which is a very common arrhythmia as well. The most common cardiac arrhythmia, however, still is AFib if you look worldwide. But there are definitely other causes for this fluttering sensation in your chest that can be investigated by your doctor.
Okay. Thank you for that question, Erica. Our next question is from Joseph. He asks, what about ED drugs and AFib? Are they okay to take?
Erectile dysfunction drugs, I think, is what the question was regarding. So in terms of those medications, it is important that when your doctor starts those medications, there are no other things, particularly what were called nitrate medications, that may interact with the ED drugs. There isn't any particular thing that I worry about in terms of interactions between AFib and the ED drugs. That being said, erectile dysfunction is often a marker of some of these other risk factors associated with AFib. So these things tend to come together, or at least you can see an association between AFib and erectile dysfunction. That being said, I'm not worried about any of those types of medications in my AFib patients, unless there's some other medication they're on that contraindicates it.
Okay. And our next question is from Mike. He asks, at what point can I taper off medicine?
Yeah. And that's something that you should really be discussing with your doctor in terms of your specific situation and the specific medications you're on. In terms of the anticoagulant, again, like I talked about earlier, your blood thinner is really based on your stroke risk score, and really, at least as of now, should not be changed dramatically even after an ablation, for example. In terms of patients, other medications like the rhythm controlling agents, in patients who've had an ablation, I'm pulling them off their rhythm controlling agents, their antiarrhythmic drugs, because we did the ablation as a means to control their AFib. So often at their 3-month or 6-month appointment, I start to wean or stop entirely, their rhythm controlling agents. So there are definitely situations where you can start peeling away those drugs, but your specific situation should be discussed with your doctor.
Okay. And thank you, Mike, for that question. Our next one is from Wana. I hope I'm pronouncing that right. Sorry if I'm not. And they asked, do the symptoms come and go away?
Yeah, as AFib can come and go away in the start, meaning that you can have an episode of AFib and it can stop and it can come back. Similarly, your symptoms will do the same, that when you're in AFib, you'll have symptoms, and when you're not in AFib, you won't have those symptoms in AFib. Now, more sort of later in the disease course, patients who may have been symptomatic in the past, they may become less and less aware after, in the future. So your symptoms can wane over time as sort of your body gets used to AFib. And even interestingly enough, AFib that used to be symptomatic may become less symptomatic even after things like an ablation. Yes, your symptoms can change over time. Earlier in the disease course, it's because you may be going in and out of AFib. Later in the disease course, it may just be that you've gotten used to the AFib and you're not aware of it anymore.
Okay. Our next question is from Joanne, and she asked, my doctor said I have SVTs, and if not fixed by medication, it could lead to AFib. What causes SVTs? Do they ever go away by themselves? And how is it related to AFib?
Yeah, great question. So there are many different types of SVTs. SVTs are a very, very common type of arrhythmia. Some SVTs may be related to some, extra pathway that you were born with, meaning that, normally there's one way for the electrical activation of the heart to go from the top chamber to the bottom chamber. Some patients are born with 2, and that can result in this sort of short circuit reentrant type of SVT. There are other type of SVTs that are just occur because some piece of tissue is deciding to beat fast and on its own at times. And these SVTs can be the triggers for AFib. So often in patients who are coming in with AFib, we will also treat their SVT because that may be a driving factor of atrial fibrillation in that patient. So is it necessary that if you have SVT that you will develop AFib? No, but SVT can function as a trigger for atrial fibrillation.
Okay, thank you for explaining that, and thank you for your question, Joanne. Our next one is from Linda, and she asks, are there any certain foods to avoid or types of diet that help? I think you mentioned the Mediterranean diet earlier.
It just as an example, there's a heart healthy diet that you can see from sort of the ACC AHA. In general, I avoid sort of fad dieting because of the changes they can do to your body. I would recommend, some people will have triggers of caffeine as a trigger for their AFibs. They may need to cut back on their caffeine intake. Some patients can have triggers of chocolate as their AFib, as a trigger for their AFib. They'll cut back on that. Patients' triggers for AFib can vary, and each patient can have a different trigger for their AFib. The things that are sort of known in terms of diet and intake wise, making sure you're not overeating, right? So making sure you're not gaining weight and make sure you try to keep a healthy body weight. And then, I didn't mention this earlier, but I'll say this here. Don't smoke. Smoking plays a big role in atrial fibrillation. So if you are smoking, talk to your doctor about how to quit and how they can help you quit smoking. And then avoiding excessive alcohol intake.
Okay. And you mentioned triggers. Is that something that you just kind of have to monitor yourself while you eat these certain
Well,
foods to
I
figure it
will
out?
say every patient's a little bit different. Some
Okay.
patients say they'll have a glass of wine and they'll go into AFib an hour later. Other
Okay.
patients will have no sense of what puts them into AFib, and it occurs very sporadically. And so in a patient who doesn't otherwise know what triggers AFib, I don't tell them specifically to avoid any specific trigger. In patients who know it, they avoid it on their own. They are already avoiding things that make them feel unwell, and so they're doing it by themselves. So there's not anything specific other things that I mentioned to avoid.
Okay. Great. Thank you for that. Our next question is from Karen, and this one is an interesting one. Does cannabis affect AFib?
That's honestly an answer that I don't have.
Okay.
There are, in terms of marijuana, in terms of smoking marijuana, there are effects that it can have on the heart. In particular, effects on AFib in terms of cannabis itself, I'm not aware of, and that'll be something that I'll have to look into myself. So it's a good question because I don't have the answer for that right now.
Okay. Yeah, thank you for that question, Karen. Our next one is from Vin. What is sinus rhythm?
Sinus rhythm is normal heart rhythm. And we call it sinus rhythm because it comes from an area of the heart called the sinus node. That is where the impulse for each heartbeat should start. But, it's a fancy way to say it's normal rhythm.
Okay, thank you. Our next question is from Mike, and you talked a little bit about COVID and its relation to AFib. But just, kind of going back to that, he asked, can COVID or the vaccine cause AFib?
Yeah, so I'm not worried so much about the vaccine as a cause for AFib. So I would again say, if you're eligible for a vaccination per the CDC guidelines, I would get one. In terms of COVID causing AFib, there's an increased risk for AFib in patients who are critically ill with COVID. And whether or not that's directly related to the virus or the effects that the virus has on your body in terms of the low blood oxygen, the stress related to the infection, the inflammation related to the infection, sort of not clear, but there is definitely a link between COVID and new onset atrial fibrillation.
Okay, thank you for that. And thank you for the question, Mike. Our next question is from Gail. She asked, if you have AFib and showed some weakness in echocardiogram, is there a way to strengthen the heart?
It's a very good question. So, it depends sort of what came first. That being said, in patients who have a weak ejection or weak heart muscle, often defined as an ejection fraction of the heart, and have AFib, there is data to suggest that if you treat your AFib, and particularly if you treat it with an ablation, but if you treat your AFib in general, that it can reduce your risk for things like admissions to the hospital with heart failure, things like death from cardiovascular causes. So there is some benefit to managing your AFib if you have a weak heart muscle. And it's possible. There are other situations where people present with AFib and their heart function is dramatically reduced. We call that, tachy-induced cardiomyopathy, meaning that their heart reduces function because their heart's beating so fast. And in those patients, controlling their AFib or whatever rhythm they're in, but in controlling their AFib, and you see improvement in their heart function, is sort of the way to diagnose that problem. So there's two pieces to this. Some patients will present in heart failure because of their AFib and their heart is going so fast for so long. And other patients who have heart failure and then are diagnosed with AFib, treating their AFib can actually improve some of these long-term issues with heart failure, like hospitalization, like death from cardiovascular causes, and the like.
Okay. And our last question is from Angelica, and she asked, what is AFib with RVR?
Atrial fibrillation with RVR, or rapid ventricular response, is just a fast heart rate with AFib. The way I think about it is in AFib, your heart, upper chamber of the heart is beating at 400 to 600 beats a minute. It's beating very, very fast. Thankfully, there's a break in between the upper chamber and the bottom chamber of the heart called the AV node that slows that impulse down so that only maybe every 60 to 150 beats a minute come through. And because of that, some patients can have faster heart rates, some patients can have slower heart rates with AFib. But it is important that patients who have AFib with RVR, even if they are asymptomatic, that RVR, that rapid heart rate, is controlled with medications most commonly.
Okay. Thank you once again for answering all those questions, and thank you everybody for asking them. We really appreciate you tuning in. So that wraps up our broadcast. Thank you, Dr. Sidhu, for joining us. And once again, thank you everybody for tuning in and sharing your questions. If you'd like to schedule an appointment with Dr. Sidhu, please call 410-554-6727. Thanks again for tuning in, and we will see you next time.
Thank you very much. It was a pleasure answering all your questions.